Hello, everyone. We are going to get started. We'll review some content for the virtual session number 3. And we're going to talk about some psych medications, migraine therapy, and thyroid treatment. So let's go ahead and get started. All right. First, we're going to start off with talking about stimulants. So, obviously, if possible, we want to try non pharmacologic therapy. However, we're in farms, so let's talk about the drugs. So, most children and adults respond to drug therapy for ADHD. It's kind of the mainstay of treatment. Um, and there's a stimulant out there that I'm sure plenty of you guys use. I know I use it every day, which is caffeine. It is consumed worldwide for its stimulant effects, and is just an example of a stimulant, but it's not typically used for ADHD, but just an example of what a stimulant is, and what falls under the stimulant categories. So let's talk about ADHD therapy. There are a number of different stimulant drugs that can be used for ADHD. Some of the more common ones are Ritalin, Concerta, Focalin, Adderall, Vyvanse. There's really no data to support use of one stimulant over another. If one stimulant is ineffective, another should be tried before considering a second-line agent. So make sure to review the mechanism of action of each of the stimulants. CNS stimulants increase the activity of the CNS neurons. Most of the stimulants act by enhancing neuronal excitation. A few act by suppressing neuronal inhibition. But one thing to note is that at a high enough dose, all stimulants can cause seizures. So the stimulants, of course, are used for ADHD, but they can also be used for narcolepsy. So there is a black box warning for amphetamine abuse. The black box warning states that amphetamines have a high potential for abuse and dependence. In patients who are on amphetamines chronically, they may have withdrawal if suddenly stopped. And then there is also a black box warning for methylphenidate. Chronic abuse can lead to marked tolerance and psychological dependence with varying degrees of abnormal behavior and possible frank psychotic episodes. So as a class, stimulants have similar side effects. Obviously, every drug has its own side effect profile, but in general, stimulants cause, of course, CNS stimulation. So you're going to have decreased appetite, weight loss, irritability. Often, depending on the medication, but a lot of the time, you're going to have a rebound effect when the drug wears off. So in kids, you may see more impulsive behavior and increased hyperactive state. There are some cardiovascular effects, like an increase in blood pressure and heart rate. We, of course, want to use very cautiously in patients with history of pre-existing cardiovascular disease. In Ritalin specifically, you may see tics or gross suppression when taken at high doses. So there's a paragraph in our textbook that says, do amphetamines increase the risk for sudden death? And the answer is probably not, which is not a great answer, but that's what they say. So therefore, they say routine ECGs are unnecessary before starting a child on a stimulant. However, it's unnecessary if they don't have a history of heart disease. If they do have a history of heart disease, then an ECG would be appropriate. So just something to keep in mind. You can read more about that in our textbook if you want some more info. And then the other thing is, in children, we definitely want to monitor their height and their weight and make sure they're growing when they're on stimulants. Some parents choose to take a drug holiday in the summer when the kids aren't in school. Otherwise, you just need to make sure a lot of times these, kids may end up having issues with their growth because they're not eating enough. So it's just something to keep in mind that we need to monitor the child's height and weight. Then we have modafinil, Alert, which is a unique non-amphetamine stimulant. And this is typically used for narcolepsy. It can be used for shift work sleep disorder, obstructive sleep apnea, hypoapnea syndrome. But basically, Alert promotes wakefulness in patients with excessive sleepiness. No one exactly knows how modafinil wards off sleep, but the drug does seem to influence the hypothalamic areas that are involved in maintaining the normal sleep wakefulness cycle. And then let's talk about ADHD treatment with non-stimulants. So non-stimulants are actually the second choice drugs in treating ADHD. The reason is they're not as effective, but the good news is that they're not controlled substances. So some parents are super against putting their child on a stimulant, which is fine. Everyone has their own opinion, but you just have to let them know that it's probably not going to be as effective. But some kids do totally fine, and even adults do totally fine on a non-stimulant. So the second line treatments include clonidine, guanfacine, and Strattera. Strattera is used, it's used a good amount. It's a norepinephrine reuptake inhibitor. It's approved for ADHD in children older than 6 years old. The thing is, it may not work for several weeks, so that's unfortunate, but it does carry less risk of abuse than stimulants. It works by eliciting a selective inhibition of the presynaptic norepinephrine transporter, and it has been shown to improve symptoms of ADHD. Okay, now we're kind of switching gears and we're going to talk about the antipsychotic agents. So antipsychotic agents are used for a number of things. They're used for schizophrenia, bipolar, delusional disorders, drug-induced psychoses, depressive psychoses. One thing to note is that antipsychotic agents, contrary to whatever you've seen done in the hospital, really shouldn't, for purposes of the text and everything and testing, should not be used to treat dementia in the older adult because there's an increased risk for mortality. So they may still commonly be used off-label to treat dementia related to psychosis, but they really shouldn't be. And we'll talk about that more in a minute. Okay, so we have two types of antipsychotic drugs. They fall into two major groups. So we have the first generation antipsychotics, the FGAs, which are known as the conventional antipsychotics. And then we have the second generation antipsychotics, the SGAs, which are known as the atypical antipsychotics. So all of the first generation antipsychotics produce a strong blockade of dopamine in the CNS. As a result, they can all cause serious movement disorders known as extrapyramidal symptoms, or EPS. Some other adverse effects that may be seen include QT prolongation, malignant neuroleptic syndrome, tardive dyskinesias. This class of medication can elevate lipids and triglycerides. We don't want to use the antipsychotic agents in the elderly. They're at a higher risk of death. So there's actually a black box warning about this, as you can see. So we definitely don't want to use these in the elderly. Some things to monitor in our patient that is taking a first generation antipsychotic. You're going to want to monitor a fasting blood glucose and a lipid profile. Look for those EPS symptoms, like inability to stay still, dystonia, Parkinsonian type symptoms, tardive dyskinesias. The second generation antipsychotic agents produce a moderate blockade of receptors for dopamine, but a much stronger blockade of receptors for serotonin. Because dopamine receptor blockade is only moderate, the risk for EPS type symptoms is lower than with the first generation. As you can see here, there's a number of different drugs in this class. I just listed some of the more common ones that you may see used: Zyprexa, Seroquel, Geodon, etc. So a few things is there are some adverse effects. All of them have the potential to cause weight gain. So you want to check the BMI on the patient, check weight every 3 months. Because of this weight gain, there's always a risk for type 2 diabetes. So we want to monitor that in the patient. Specifically, Geodon should be monitored for QT prolongation. Geodon should not be given to patients at risk for Torsades de Pointes. Clozapine specifically accelerates the rate of cell death in neutrophils, creating prime conditions for gram-negative septicemia to take root and produce agranulocytosis. So prior to starting treatment with clozapine, a white blood cell count and absolute neutrophil count must be assessed and monitored throughout the course of treatment. All right, now let's talk about bipolar disorder. I'm sure you guys are all familiar with bipolar disorder, but it's a disorder characterized by mood instability, alternating cycles of mania and depression. The mainstays of therapy are lithium and valproic acid, which are the mood stabilizers. Patient may also receive an antipsychotic or an antidepressant in some cases. This is a condition that the patient will have to be treated for forever. It's a lifelong condition. So there are a number of different medications, like I listed before, that can be used for bipolar disorder. Again, the mood stabilizers are lithium and valproic acid. There's a nice table that summarizes in our textbook that summarizes which medication can be used for an acute management of a manic episode, what should be started. And there's a lot of good tables in our text if you want to take a look at that. Antipsychotic drugs are often given to help control symptoms during severe manic episodes, even if there's not psychotic symptoms that are happening. Antipsychotics can be used alone, but typically they are used with a mood stabilizer because of the reasons we talked about before. Second generation antipsychotics are typically preferred. Antidepressants may be needed during a depressive episode. However, in patients with bipolar disorder, antidepressants are always combined with a mood stabilizer. There's been this long-held belief that when used alone, if an antidepressant like an SSRI is used alone in bipolar disorder, it may elevate the mood so much that it could cause hypomania or a manic episode. There's some studies that have come out that state that it's not as much of a risk as they initially thought, but nonetheless, the current guidelines suggest using only an antidepressant if there's a mood stabilizer present. And we'll talk some more about lithium because lithium is, used quite frequently, and it does have some monitoring parameters that we need to consider. So lithium is used to control mania, prevents relapse, reduces suicidal drive in bipolar disorder and unipolar depression, and helps to prevent bipolar-related cognitive decline. So lithium is a naturally occurring salt that causes numerous biochemical reactions in the body. It's actually completely absorbed in the GI system, distributed throughout all of the water in the body. It is not liver metabolized because it's a naturally occurring element. It's excreted 95% by the kidneys. It's thought that lithium decreases excitatory transmission in the neurons by lowering the levels of dopamine and glutamate, and increases inhibitory transmission by increasing GABA and increasing serotonin. It is thought that it increases brain volume in the hippocampus and amygdala and the prefrontal lobes. Excuse me. So the two things lithium blocks are the release of dopamine from the nerve terminal, and it blocks postsynaptic signaling by blocking the formation of IP3 and blocks the increase in intracellular calcium. So something to note is that it does take about 1 to 3 weeks for the levels to develop, but we do really want to, we have to monitor lithium levels because lithium has a low therapeutic index. So as a result, toxicity can occur at blood levels only slightly greater than therapeutic levels. So lithium level has to be below 1.5. The therapeutic range ideally is 0.4 to 1.0, but the preferred range, you could say, is 0.6 to 0.8. We're going to measure these levels every 3 to 6 months. And we're going to check a serum trough level, which is 12 hours after their last dose. Acute lithium toxicity, you may see the patient with delirium. They may have seizures, tremors, ataxia, renal failure, nausea, vomiting, diarrhea. There's possible interactions between lithium and thiazides, loop diuretics, NSAIDs, and anticholinergics. And some of these may increase the risk for lithium toxicity. So there is a black box warning associated with lithium that states, as you can see here, lithium is associated with hepatotoxicity and pancreatitis, usually during the first 6 months of treatment. Children younger than 2 and patients with mitochondrial disorders are at the highest risk. And lithium is also linked to increased fetal risk, particularly neural tube defects and other major malformations. Epstein's anomaly is a congenital heart defect that can be caused by lithium. So lithium is contraindicated if the patient has complete sodium depletion, dehydration, significant renal or cardiovascular disease. Some safety monitoring, we're going to want to do a serum creatinine, a GFR, TSH, chemistry profile, and an EKG if there's cardiac risk factors. Adverse effects, there are quite a few different adverse effects that can occur. Some notable ones, inhibition of cardiac potassium channels and repolarization in arrhythmias. I think arrhythmias got cut off, but that's all it says there. It can block ADH. It can cause hypothyroidism or goiter, hyponatremia and hypokalemia. Early on, the patient may experience GI side effects, but those typically go away. The polyuria and thirst can happen, but that does typically go away. Tremors, renal toxicity, and then of course the concern if taking it while you're pregnant, which is not recommended. Okay. So let's switch gears here and talk about anxiety. So there's a number of medications that are used to treat anxiety disorders. Serotonin and norepinephrine are inhibited in generalized anxiety disorder. And here's some medications used for anxiety disorder. And then we have antidepressants. So there are a number of medications used to treat depressive disorder. There's a good amount of overlap between drugs used for both anxiety and depression. It is thought that or the Monamine hypothesis says that in depression, there's a deficiency of dopamine, norepinephrine, and serotonin. One little note I want to make when starting a patient on an antidepressant, or if there's new onset depression, excuse me, I'm moving around my chair, is that a patient with a new episode of depression, you want to do a TSH to rule out depression. Sometimes that may be the first presenting sign. So just a thought is consider that. So a couple of things to remember with antidepressant therapy is that the patient should continue antidepressant therapy for 4 to 9 months after symptoms resolve. So a lot of patients feel better, they want to stop their medication. No, they should continue it for at least 4 to 9 months after symptoms resolve. And then a lot of times the patient, depending on what the medication the patient is taking, they will need to wean off the medication, depending what it is. It is said that most of the antidepressants are nearly equal in efficacy, but it just depends on the side effect profile and drug interactions. So usually first choice drugs are the SSRIs, the SNRIs, or Wellbutrin. Older antidepressants like tricyclics and MAOIs have a lot of adverse effects, and they're not as well tolerated. So they're typically used, when patients haven't responded to first-line drugs. So sometimes you can use the patient's, symptoms to match them with the right drug. For example, a patient with fatigue could choose a drug that causes CNS stimulation like fluoxetine or Wellbutrin. If a patient has insomnia, you can choose a drug that has some sedation. If a patient has sexual dysfunction and depression, you could choose Wellbutrin, which is a drug that enhances libido. For a patient with chronic pain and depression, you could choose something like duloxetine or a tricyclic, which can also help relieve chronic pain. So once a drug has been selected for initial treatment, you really want to use it for 4 to 8 weeks to assess its efficacy. As a rule, the dose should be low initially. We don't want them to have a lot of side effects, of course, and then gradually increase. If the initial drug is not effective, you can, if increase the dose of the same drug. You can switch to another drug in the same class, switch to a drug in a different class, and then add a second drug, such as lithium or an atypical antidepressant. But typically by that point, if they're resistant to a lot of treatment, you will probably be referring them out. Okay, so something to think about is serotonin syndrome when we're talking about antidepressants and medications used for anxiety disorder. So this is a syndrome that's caused by too much serotonin. It's often caused by a combination of drugs that can raise serotonin to high amounts. A lot of times this happens not on purpose. The patient just doesn't realize they're taking drugs that can cause an interaction, and they fail to disclose to the healthcare provider what they're taking, resulting in this syndrome. The patient will experience acute onset of symptoms, mental status changes, shivering, high fever, muscular rigidity. A number of different symptoms may occur. This can happen when taking a combination of any of these supplements and drugs: SSRI, St. John's wort, MAOIs, tricyclics, triptans, tramadol, dextromorphan. Really, the rule of thumb says that if you're switching from a drug that deals with serotonin to another, you need to wait 2 weeks. Okay, so let's talk about SSRIs. So these are probably the most used antidepressant. They've been around since about 1987. SSRIs inhibit the reuptake of serotonin. They do this by blocking the serotonin transporter, resulting in an increase of serotonin to bind to the postsynaptic receptors. Used for anxiety, depression, PTSD, and OCD. Panic disorder. So a few things to note is that SSRIs can take 4 to 6 weeks to take effect, but they are really great drugs once they work. So a couple of things to note is that patient can experience withdrawal syndrome if they stop their SSRI abruptly. So this usually happens if they've been using the SSRI for longer than 5 weeks. Basically what happens is there's a sudden change in the amount of serotonin available. There's an alteration at the receptor site. And typically it takes about 3 to 5 half-lives before the drug clears. Drugs with a shorter half-life may not have as many symptoms as those with a longer half-life. So it just depends on what's going on there, or which medication they're taking there. One SSRI, Celexa, used in depression and OCD, can have their adverse reaction of QT prolongation. It can exacerbate pre-existing cardiac dysrhythmias. If the patient has a history of cardiac dysrhythmia and they're using Celexa, they need to be monitored closely. Try to avoid in patients over 60 because there's a higher risk of QT prolongation there. Zoloft or sertraline is in the class of SSRIs, obviously very commonly used medication for anxiety, depression, first-line medication in postpartum depression in mothers that are breastfeeding. Commonly reported side effects to Zoloft are sexual dysfunction, drowsiness, and mild weight gain. A lot of the SSRIs have mild weight gain and sexual dysfunction as side effects. This is a little bit of a touchy subject, of course, but what is the advantage of using an SSRI in a patient that is suicidal? And unfortunately, suicidal patients often try and overdose on their pills, such as tricyclics or anything else that they're taking. And if a patient were to overdose on a tricyclic antidepressant, they can die from cardiotoxicity due to those sodium channels. If a person tries to overdose on an SSRI, if taken alone, typically it's not fatal, but obviously there's cases it can be, but not nearly as risky as if they try and overdose on like a tricyclic. SSRIs, there are 2 SSRIs that are potent inhibitors of CYP2D6, and that's paroxetine and fluoxetine. Common side effects when starting an SSRI, a dull headache is commonly seen in the beginning, nausea and diarrhea. Taking the medication with food will help. Again, like I said, sexual dysfunction can occur, and weight gain is a common complaint. And we talked about the interactions that can result in serotonin syndrome earlier. Okay, let's talk about the SNRIs. These are selective norepinephrine reuptake inhibitors. So they inhibit the reuptake of serotonin, and they do this by blocking the serotonin transporter, resulting in an increase of serotonin to bind to the postsynaptic receptors. What does that sound like? That sounds like an SSRI, right? But they also inhibit the norepinephrine transporter, resulting in increased levels of norepinephrine, which then bind to the postsynaptic receptors. So some examples of these are venlafaxine, duloxetine, desvenlafaxine, used for depression, anxiety, panic disorders, may also be used in neuralgia or neuropathy type pain. The thing is, with the SNRIs, they have the negative side effects that are seen with serotonin with SSRIs, but they also have norepinephrine side effects. So the serotonin side effects that you may see are the sexual dysfunction, constipation, nausea, but then the norepinephrine effects seen, you may see an increase in blood pressure or heart rate, insomnia, or agitation. Tricyclics and SNRIs are similar. They have a similar mechanism of action, but the SNRIs are actually more selective than the tricyclics. So SNRIs are preferred over tricyclics. Venlafaxine has a dose-dependent effect. At lower doses, it has more serotonin effects. At higher doses, it has more norepinephrine type effects. And then common side effects, especially with venlafaxine, are like drowsiness, sleepiness, with its anticholinergic type effects. Tricyclic antidepressants are found to primarily inhibit the reuptake of serotonin and norepinephrine by blocking both of their transporters. Over time, this induces the adaptive cellular response that are ultimately responsible for relieving depression. Different agents, different tricyclics do this with different levels of selectivity. The thing to note with tricyclic antidepressants is they also block alpha receptors, muscarinic receptors, and histamine receptors, which causes a lot of unpleasant side effects. Some examples are amitriptyline, nortriptyline, doxepine, mainly used for depression, also can be used for migraines or neuropathic pain, insomnia, but common side effects are some of the anticholinergic effects that may be seen, constipation, maybe prolongation of the QT interval, orthostatic hypotension, dizziness, dry mouth, urinary retention, can block cardiac sodium channels and cause similar effects to some of the antiarrhythmics, which can lead to cardiac conduction abnormalities. So just keep this in mind. So again, the most serious adverse effect of tricyclics is cardiotoxicity, which can be lethal if taken in overdose. Tricyclics should not be combined, especially with an MAOI. Really, most of these that I'm talking about shouldn't be combined because of the risk for serotonin syndrome. But if an MAOI, which we'll talk about in just a second, and a tricyclic are taken together, a hypertensive crisis can occur. Okay, so the monoamine oxidase inhibitors are the MAOIs, is an enzyme that degrades monoamines such as serotonin and norepinephrine. So these are rarely used anymore, but I'm sure you're still going to see a board question about them. So they're another class of drugs that can be used to treat depression and panic disorder. Some specifically are used in Parkinson's disease and social phobia disorder. They're really second or third line treatment because they just have a lot of side effects. This class inhibits MAOI, which increases its availability. This allows for an increase of norepinephrine and serotonin, resulting in its antidepressive effects. So basically the main thing, which is why I put a picture of it here, is that we need to teach our patients that if they're taking a drug in the MAOI class, they need to avoid foods containing tyramine. So things like wine and cheese should not be taken or not be eaten or drank when they're taking these drugs. Some examples of medications in this class are Nardil and Parnate. We always want to watch the blood pressure in our patients taking this medication in this class. And again, they really can't be combined with any of the other medications. So Buspar is a good drug. It is a drug that binds with high affinities to the receptors for serotonin and lower affinity to receptors for dopamine. Buspirone or Buspar is not a CNS depressant. It treats anxiety, and it really has almost the same efficacy as a benzo, but it has two distinct advantages. So there's no abuse potential and does not intensify the effects of other CNS depressants like alcohol or barbiturates, benzos, or any other related drugs. So the negative is that it's not a once-a-day dosing, and the effects develop slowly. So initial response takes at least a week to appear, maybe several more weeks before the response peaks. It is not suitable for PRN use. It needs to be taken every day to be effective. But it is great because there's really no abuse potential. If a patient has a history of alcohol abuse or drug abuse and they don't want to take anything addicting, this is a good option. It's good in the elderly too because there's not as much psychomotor impairment, there's not as much sedation, and metabolism is very straightforward. There's no active metabolite. So should not be used PRN, but unfortunately is multiple times a day dosing. So that is a negative. And make sure you don't confuse Buspar or Buspirone with bupropion or Wellbutrin. So this is called an atypical antidepressant. So it does have a unique structure that's similar to an amphetamine. It has similar kind of stimulant actions and suppresses appetite. The antidepressant effects begin in 1 to 3 weeks typically. 1 second, please. The mechanism of action by which the depression is relieved is not entirely clear, but it's believed to be related to the blockade of dopamine and norepinephrine reuptake. In contrast to the SSRIs, Wellbutrin does not cause weight gain or sexual dysfunction. In fact, it appears to increase sexual desire and pleasure. So sometimes it's taken to counteract those effects in patients taking SSRIs. So a few things to consider with Wellbutrin. It's a good drug. It's also used for patients that are trying to quit smoking under a different name. But the two major drawbacks are that it can lower seizure threshold and it may exacerbate psychotic symptoms. So patients that have a history of seizure disorder likely should not take this drug, and it may exacerbate psychotic symptoms. Other side effects, dry mouth, weight loss, headache, agitation, and then of course, seizures. Seizures is the main thing you'll probably see or be tested on in relation to Wellbutrin. And then let's talk about benzos. So some info from our text says that all the beneficial effects of benzos and most of the adverse effects result from the depressant actions of the CNS, in the CNS. As the doses increase, the effects progress from sedation to hypnosis to stupor. So lower doses are preferred. So benzos depress neuronal function at multiple sites in the CNS. Benzos potentiate the action of GABA, and benzos do not act as a direct GABA agonist. They simply intensify the effects of GABA. Because of this, there's a limit to how much CNS depression that benzos can actually produce.